Evening. My name is Skip Foster, and on behalf of the Village Square and our partner, the Tallahassee Democrat, I want to welcome you to COVID in Tallahassee, a conversation with Tallahassee Memorial Healthcare's president and CEO and friend of mine, Mark O'Brien. This is an update on the conversation we had some weeks ago that really got a great response, and that was due to some of the terrific information that Mark shared and the questions of yours that he answered. So I've got a nice long list of them here from me, but more importantly is the excellent ones that you will submit. So you should please click on the Q&A link that you will find on your Zoom page and submit those. You don't submit them now, you don't have to wait till the Q&A starts. So please do that. Tonight's conversation is being recorded and is also being broadcast live on Facebook on the Village Square page, Tallahassee Democrats page, and TMH's page as well. So, Mark, how are you?
Great.
Good. Well, let's get started. And the first question I want to ask you is just a very broad, give us your overall assessment of where we stand with the virus right now locally.
It's evolving every single day. We've seen a lot of activity, of course, since our last engagement. Right now, it seems to be relatively steady in spite of a lot of changes through our market, kids back in school, college back in session, all of that. But when you look at the numbers, just in the last few days, we seem to be trailing off to a pretty even, manageable level of positive rates. Hospitalizations tend to be relatively steady. We're up a little bit this week, but compared to where we were a couple of months ago, we're ranging from the mid-teens to the low 20s, and that is significantly less than what we were fearing at the very beginning of this. That is, like I say, we don't want to see any patients in the hospital with COVID if at all possible, but recognizing that that's not the possibility, it's certainly a manageable number.
So let's talk about the hospitalizations and the fears that you had. Y'all have been somewhere in the teens now for quite a few weeks, and the state numbers finally stopped dropping after getting, about a third of where they were in July. Why do you think the fears weren't manifested here? Why do you think we have fared better on hospitalizations than was maybe originally thought?
From the very beginning or most recently?
Most recently.
Well, I think the concern was with college kids going back into the community, coming back into the community, that they would be spreaders, and typically college kids aggregate, they don't wear masks, they contract the disease because they are in such close proximity. The concern was that those college kids would then make their way out into the community, or at least be in contact with those in the community, and then it would basically ripple out from there. Also, I think there was a general concern that when we put kids back in the classroom, that in fact, that would also create opportunities for very young children to contract it, recognizing that they may do well, but they all also return home every evening and expose their parents, grandparents, or other people. We haven't seen that, at least not to the levels that anyone really thought might be possible on the negative side. And there are probably a variety of reasons. I think the college kids tend to aggregate more than people thought. And you and I have talked about this, probably the safest place to be in Tallahassee for COVID is going to be the FSU campus, the FAMU campus, the TCC campus, somewhere end of October, early November. And that's because they probably are going to be the first group to get to herd immunity. The school-age kids, quite frankly, we have a relationship with the Leon County schools as it relates to testing. We've stood up a very aggressive, very state-of-the-art testing partnership with FSU. And this is PCR testing, by the way, and we have a relationship with Leon County schools to test their folks who, following their protocols, identify as as potential COVID, we're seeing actually many fewer in that testing queue than we thought we might see. Partially, I think, because they're holding up to guidelines. Kids are wearing masks. They're sending people home when they are sick and making them quarantine. One of the things that we did, we helped provide, working with the community sewers, to provide what we call H600 mask. It's a different step, certainly higher than your typical surgical mask or cloth mask. It's designed to not just protect others. We often talk about the role of the mask to protect others from you, but these actually do both. They protect not just others, but also protect you from anything that comes in. And we provided everybody who works in the school system with those H600 masks. And that, I think, might have an impact on that as well. So we might be seeing a little activity in those populations, but we're not seeing the push out.
So do you have any other theories, because I guess the college kids, I mean, school started generally late August, early September. So if we were going to see a big kind of wave in hospitalizations and other types of infections, getting passed from younger to older, theoretically, that would have happened by now. Am I correct in saying that?
Yeah.
And so
I would say other factors.
Yeah.
I think certainly there are underlying attributes of an individual's health that put them at risk, and I think patients or individuals who have those comorbidities, I think, are a little bit more sensitive. I think there's a set population of our community who recognize they're at risk, whether they're elderly or whether they're diabetic or have an obesity issue, COPD, whatever the case may be. Maybe it's a series of those. But I think those people are wisely staying holed up. They're living in their cave until we get through this. I think also there's just the general tendency for people to be compliant with the guidelines out there. I think mask wearing does help. I mean, if you look at the numbers and the trend lines generally across the country where they've implemented it, it's gone down. I'll tell you an amazing statistic. In fact, I didn't believe it. I had to read it twice, a third time. But when it comes to flu, influenza, flu is a virus, just like COVID, and it gets spread normally through touch or airborne activities. We watch flus, and quite frankly, we follow trends in flus by what happens in the Southern Hemisphere. Their winter precedes our winter. They just finished their winter. An amazing number. This past year, their influenza rates were down, and this is Australia, New Zealand, Chile, South Africa. Their flu rates were down 99% compared to prior year. Yeah, exactly. I actually had to read that twice. And the question, why did that occur? And they are attributed to social distancing, masking, better hygiene. So that tells you that if they're down 99% flu by being compliant to general protocols, and it's a virus that spread very similarly, even though it's more contagious than the flu, then there should be an impact on following those guidelines here. Does that make sense?
You're not telling me that I'm going to have to wear one of those masks like the rest of my life, are you?
Well, I will tell you, actually, I was talking to some of our team this morning, and we're going through that number. And the acknowledgement was, yeah, well, if you know someone who has the flu, they should be wearing a mask. And
Right.
We've never thought of that before. I'm not saying everybody needs to wear a mask all winter long, but if someone has the flu, someone thinks they might be coming down with the flu, it probably would be a bad idea for them to pull that cloth mask out of their old COVID drawer, wash it really good, and put it back on.
We're already getting some good questions coming in, and if I see something that's being fed to me that's right on point for our conversation, Mark, I'm going to go ahead and ask it.
Sure.
And this question, if it's, look, viewers, Mark is the CEO because he knows a little bit about a lot of things, not necessarily because he knows a lot about any one little persnickety thing. So Mark, if you don't know the answer to this, we'll just move on. But
Yeah.
somebody asked, what's the difference between the H600 and the N95 mask? Do you know the answer to that, and
Yeah.
which is more protective?
Well, an N95 is more protective typically because it's a one-time use and it's designed for this. H90 and H600 is really more or less an invention of COVID. It is basically surgical wrapping cloth, cloth that we use to do surgical wrappings for sterilization processes. We take that material and we make masks out of it. So it has a density to not allow anything to pass through it other than limited air. And it's washable. You cannot wash an N95. It's a one-time use. Whereas an H600 can be washed many, many, many times until there's a degradation of the fabric. So
Okay.
that's pretty much the difference. But to your point, just as a reminder, I am not a physician. I'm not an epidemiologist. I'm a normal guy who is around this a lot and tries to read and absorb as much.
Well, it helped, honestly. I think it helps you communicate this stuff in a way that people can understand. So we thank you for doing this and putting yourself out there. And I'll try to weed out the questions that ask you to, dissect an amoeba to, or whatever, give an answer like that. So,
to answer your, but to add on to that real quick, you can't buy an H600. It's not in the store. We basically have been providing those to our community. We certainly provided them to our staff internally, but we gather the materials, and there have been a whole group of sewers in our community. Cannot thank them, but they've taken that material and have created masks out of them. And I think it's a lesson that I think a lot of health systems have adopted across the country. We learned that early on.
So you talked about the relatively low positive test rates in secondary schools, in the K-12 schools, right? And then the other kind of fear that was anticipated is that there would be transmission from those students when they came home to their parents, right? So you can control them in the school atmosphere to some extent, and then they come home and you don't really know what happens. Have you seen that spread from school children, even in the low numbers, and from the college kids to the older population, or has that not really materialized?
We haven't seen it materialize. Now, when I said we're working with Leon County Schools, what we're doing is we're testing their staff, not necessarily students. The students are the responsibility of parents and they get tested through that vehicle. But when a Leon County employee, teacher, worker, whatever, has a series of symptoms or whatever else, they have a criteria, they then get sent over to our testing site, we test them. And that number has been lower than we anticipated. So that is an indicator that there is not as much spread, at least within the classroom, to the workers, the teachers, et cetera, that we feared.
This is something you and I haven't talked about. It seems like there are events or interactions that are highly contagious, and then those that aren't, and that even some that aren't, you would think would be, like, so the football game where there were the pictures of people, many of them not met, by now, that was 1, 2, 3 weeks ago. If that had caused something, you would have known it by now, right? And it didn't. Yet, some other interaction of people is there any success in untangling the kind of weird discrepancy between super spreaders and non-super spreaders? Is it like individual makeup? Is it a certain way people interact? Do you know anything about that, or is that still just in the research phase and we hadn't figured it out?
Part of it's just the mystery of COVID. I'm not certain that we'll completely understand this thing as we hopefully get rid of it in the future. I think one of the things that is pretty evident is that it's not just a proximity, but the environment in which people spread it. A closed environment, a closed room, poor circulation, those, you're going to have droplets hang in the air, and those droplets don't have a way to dissipate or move on. So I would say that typically your normal outdoor event, if you're even if you're spread apart some, it's likely to be less risky than being in a room with 40, 50, 100 other people, even with mask on, but certainly without mask. You're just creating an environment where you better start counting, you anticipate you're going to be counting positive COVIDs in the future.
So here's another audience question that I'm going to kind of recast a little bit. So there was this spring narrative of, oh boy, can't wait for summer to get here because the sunlight's going to kill all of the evil little COVID forces. And that not only didn't happen, but the opposite happened in the Sun Belt. And so this question from a viewer is, are you concerned that the onset of winter and people spending more time inside will lead to an uptick? All of that I want to just ball up and say, what do we know about the seasonality of COVID right now? And do you think the winter will be a big uptick or not?
Well, I think I think the fallacy of our line of thinking that summer was the summer heat and the sunlight and the ultraviolet rays were going to kill COVID. I think that was wishful thinking. But the reality is we're in the great state of Florida, which is also the great state of air conditioning. People don't stay outside all day long. In fact, if anything, during the heat of the summer, everybody stays inside, which in fact probably lends itself to a greater risk of spreading COVID than a fair weather month where people might be outside running or in the winter. I do think that anytime people aggregate indoors with poor circulation, is going to create a more favorable environment for the virus. But I tell you, you and I have talked about this a little bit. I don't think we're dealing with the same. Now, this is me, Mark O'Brien, not an epidemiologist speaking. But I think if you look at the numbers and you look at the impact it's had over the course of the last 8 months now, 6 months, 7 months, we're dealing with a different virus. I think, as in all things, they evolve. And the one thing about viruses that I think everybody who works with them will tell you is that they desperately want to survive. Viruses desperately want to survive. COVID desperately wants to survive. And the best way to survive is to put yourself in a position where you can pass from one host to another. And the way you do that is by creating the least amount of harm possible that will allow that host to then effectively engage with others. So if you're a COVID-19 virus and you infect your host and you kill your host, that host is no longer spreading you. Actually, even if you're a COVID-19 virus and you infect your host and that host is so sick that that host quarantines for a period of time, again, you are not an effective virus. You're not passing yourself along. The milder the symptoms that you can create in your host, the more apt you are to pass on. So over the spread, it's still incredibly dangerous. It still kills people. But I think in general, when you look at the bodies being thrown in refrigerated trailers in New York, we're not dealing with the same COVID virus now than we were then. I think it's still killing people. I think people with high comorbidities, the high risk populations, I think those people are certainly at risk. I think there is some sort of underlying DNA attributes that sometimes gets what would normally be defined as healthy people. But overall, I think it's less deadly than it was before.
Not surprisingly, the audience questions are better than mine, so I'm going to keep going off of my sheet to the questions that our viewers are sending in. And this one is simple. If a person is at higher risk due to age or health issues, should they continue to try to isolate as much as possible? Sounds like you're going to say yes. Okay, great.
Yes.
And here's another one. Should employers change their practices in response to the recent reports regarding the transmission of the virus? So there's been some new guidance from the CDC on it being airborne and traveling more than 6 feet. How has that changed? Let me ask it to you this way. How has that changed how the hospital has approached things, if at all? Or is this still one piece of data and too soon to do any big kind of changes in the way businesses and workplaces operate?
Well, I will tell you what, I will tell you as it relates to TMH, it hasn't changed our outlook on how we engage with patients. We have a restrictive entrance policy. We have limited our points of entry. We're a large footprint here, as you can imagine. There's a lot of entry points. We've closed them all down with a limited number. We monitor everybody who comes in. We provide temp checks. We require masking. We've significantly limited visitors, all in an effort to reduce points of exposure. We have a very strict PPE policy for our own staff. We have adhered to that from the very beginning. So I don't think that any of those announcements are revelations to anybody. I think we already knew that they were airborne. We knew that the 6 feet was kind of an arbitrary number. And if you know anything about airborne particles, they're certainly going to travel. I think what most people are thinking is the direct talking airborne, the projection. So our position has been, we're going to continue with the same protocols we've been following. We're still focused very strongly on negative pressure rooms for our patients. We do not put COVID patients in any place but negative pressure rooms. All of those things are still, we strictly adhere to those things and haven't changed a thing.
Yeah, so keep going with those, because I'm not sure everybody's familiar with all of the steps that are being taken. And of course, we're, I think, fresh on everyone's mind is the news of Coach Bowden and the President and Mrs. Thrasher, you know, high profile, really icons in our community. And in the case of Coach Bowden, the family, you know, had said that he had been hospitalized previously. I know privacy forbids you to even acknowledge them or that they were, if they were at the hospital. But what I want to get at is, for those not being treated for COVID, you mentioned the negative air handling. What else is being done to protect those people? And then on the other side, do you anticipate any relaxing of any hospital policies when it comes to visitors? We got a question in chat about someone whose daughter is expecting, and then there's a limit on the number of people in there. So how is that balance working, and how can you assure folks that if they have a completely un-COVID related procedure, that everything is being done to keep them safe at the hospital?
Well, that's there's a lot to that question.
Yeah.
First of all, let me just say that we are doing everything possible to prevent the spread of COVID. Our first responsibility is to keep the patient safe. And that means taking measures that may not always be, I won't say in the best interest, but may not favor the family members, et cetera. As it relates to visitor policies, I don't see us changing our visitor policy. We do allow 1 visitor per day. That's our limit, and we think that protects patients as well as our staff. We do have exceptions to that when you have end-of-life issues and you have traumatic events. We do bend the rules for that, because we recognize that at those points that, quite frankly, there are things that are more important. So it's not hard and fast, and we try to be empathetic in those situations. But when you look at our different environments, things we're doing, for example, any surgical patient requires a negative test in advance, so we don't bring those in. I mentioned our PPE policy. We do isolate COVID patients in COVID-specific units. We have people who are trained specifically in that area to make sure that they don't spread it outside the units. The negative pressure, of course, keeps all that airborne activity within that unit and pulls it up through filters so it doesn't get spread out. We have COVID-specific physicians who have been phenomenal. It's all they do is do research on how to treat patients. When you look at things like our skilled nursing facility, we actually test every patient coming in. We test everybody every day. We do temp checks, et cetera. We test every colleague and every patient every week. to determine. That's a state guideline, actually, which I think is a progressive, very effective, wise approach. We're following those state guidelines. Generally speaking, our job is to keep everybody safe. And actually, it works. When you look at, for example, our emergency room, our Bixler emergency room in Northeast, and those folks, when you look at our physicians and staff, nurses, they're exposed to everything. And we have worked very hard to keep them protected. And so far, and I'm going to go knock on wood saying this, there has not been one transmission of COVID, of a COVID infection from a patient to one of our staff members. Likewise, on our COVID units, our staff up there, Jacqueline and her team, have been very effective in PPE, and not a single one of our COVID team members on 5A in particular has contracted COVID from a patient, even though they're dealing with COVID patients every single day. So you can limit, but we need to recognize that the prevalence of COVID in the community is it's all over. The concept of contact tracing that was all the talk early on, you know, you might as well throw that away, because the truth of the matter is when people contract it very, very, very often, they have no clue where they got it. It's not as if they knew somebody. Now, sometimes that occurs, and in those cases, we identify that. But generally speaking, the prevalence throughout the community is such that you can get it anywhere, and anybody can get it at any point in time and not know it.
Okay. So the last time we spoke, you were very concerned about the high number of non-COVID related DOAs at the hospital. These are people that I guess either arrive at the hospital and they've already passed away. And these would be not from COVID, but from all the other things that unfortunately kill us. Are those numbers still high? And what are you seeing in terms of patient confidence that they can safely use the hospital for non-COVID treatment?
Well, the last time we talked, our numbers were significantly down. Probably in the ERs, we were at 50% of what we normally see. Right now, we're actually probably up to about 90, 95%. Mm-hmm. Generally speaking, what we're seeing in the ER, though, we may still be seeing fewer patients, but the severity of those patients as a percentage is higher, which is telling us that the really sick patients are in fact coming in. It is a concern still. I don't think it's completely where it should. And people need to recognize the risk of dying from a stroke or a heart attack is much greater if you're having symptoms than dying from COVID if you contract it. So that's one of the messages we want to continue to stream out there, is that make wise, logical decisions. Yes, COVID is serious, but it's not more serious than a severely acute event. But our numbers are markedly better than they were before. But I would still say there's still a small percentage of people who are not seeking health care. But generally speaking, I think the confidence level is largely back to where it was before.
Okay, great. So according to the ACA site, I want to use the word prevalence. And this was earlier today, so it may have changed in the last few hours, but there were 379 occupied beds at TMH. And according to your site, there's 19 COVID patients at the hospital. So that's about 5% of your total bedded patients. That doesn't seem like much, right? That seems like a low percentage. What conclusions should one draw from those numbers in terms of the prevalence of the virus?
Again, it's clearly out there, but it's not affecting the population on a large scale that I think people feared. I think it's affecting people who are elderly, people who are at risk with comorbidities, but generally speaking, it's not what it was. I mean, there are people who are actually, we're seeing, it's the amazing thing is we're seeing people, not just young people, but young people in particular seem to tolerate it extremely well. Not everybody. There's the rare occasion where someone young and healthy and normally what you'd consider to be athletic contracts it and has a serious event. But generally speaking, we're starting to see, people in all age ranges tolerate it relatively well. What is interesting though is that even though we're seeing still, 15, 20 patients a day from COVID, what we're not seeing are the typical admissions in certain areas that we saw before. I was talking to Dr. Truman the other day, and he was telling me that we used to have, a number of asthmatic kids who would come in for inpatient. They would have an acute asthma attack and would require hospitalization. We'd have a number of those each month, a relatively significant number. He said we've gone months without any of those. It's now the rarity. We used to see, even though flu is somewhat seasonal, there is a flu that comes around every year. Again, in kids, we used to see some flu, inpatient activity, more severe flu cases. Rarely see flu anymore. So pediatric hospitals tend to be relatively empty these days. And again, maybe it's because of mask wearing, maybe it's because of some reduction of other triggers. But whereas we picked up on COVID, we've actually dropped in other areas.
Okay. Another viewer question that I think is a little bit on point here. Can a person without a temperature be COVID positive and be an active spreader?
Absolutely. Mm-hmm.
Yeah.
In fact, that's one of the dangers out there, is that this is, again, it's such a strange virus. It can affect some people in a very dramatic way, and other people it's not even a blip. I mean, they are contagious spreaders with no symptoms whatsoever. That's why, it's important as you look at tests to make sure you get the right test. And this is a testing question. When you look at the different types of tests out there, you'll hear people talk about the quick test, and quick tests are typically what they define as the antigen test. And then there's a PCR test. And that's typically the one that takes a longer period of time. Now, we have a number of platforms for the PCR test. Some are quicker. When I say quicker, within an hour or two. Some are, fortunately, I think all of ours are within 24 hours, because we now have that research lab partnership with FSU, which is phenomenal, which allows us to do a high number of PCRs in the community, whereas many communities are limited because of the number of test kits. But the antigen one is the quick test is the dangerous one, because they're relatively accurate. If you have a positive, you can be almost assured you're positive. The false positives are relatively far and few between. If you're symptomatic and take an antigen test, they are pretty good determinants of whether or not you have it. But if you are asymptomatic, they very often will create, or you have low symptoms. Low symptoms are asymptomatic. You can take that test, and very often it will not pick it up. So I'll give you an example, and this is not a political statement, but the White House changed their testing mechanisms back in mid-August. They went from a PCR testing vehicle where they were testing everybody via PCR methodology to move to a complete antigen testing vehicle, the quick test. And quite frankly, that's probably one of the contributors to the spread of COVID within that community. So that's the difference. That if I had Dean Watson on the phone, he would give you a much longer, more detailed definition of that. But you have to know the difference between the test.
Okay, so let's try to convert this into news you can use. If I'm pretty darn sick, what test would you suggest that I get? If I'm checking off a lot, well, I'm going to ask it this way. When should I get the quick test? When should I get the better test, the other test?
If you have symptoms, then probably it's okay. Now, I may want to dial Dean Watson real quick to make sure I'm correct on this one. But if you are symptomatic, it probably is okay to get the quick test, because it's probably going to pick it up, whether you have it or not, whether it's a flu or not a flu, or whether it's COVID or not COVID. In all cases, the PCR test is going to be more accurate.
Okay. And The only downside of the PCR test is that it's not an hour or two turnaround, but it's gotten a lot better. It's a day-ish, right?
In Tallahassee, it is a day,
Okay.
generally speaking.
Okay.
Here's the difference. I mean, one of them basically tries to detect proteins, and that's the antigen test, whereas the other one basically looks at the DNA factors in there. And Dr. Dennis at FSU explained this to us as we were going through this partnership with them on the testing vehicle. He said basically you take a strand of DNA, more or less, and you basically multiply that 2 to the 45th power. In other words, you replicate it 35 trillion times, as in trillion, as in T trillion. So that breadth of volume allows them to be much more accurate in determining whether you've got COVID or not.
And then there was a point where people were getting tests to reveal if they had antibodies, if they had immunity. It's from a dummy like me, that's and in a world where more and more folks have it that are asymptomatic that may not even know they ever had it. It seems to me there'd be some value there, but I don't really hear much talk about that happening anymore. Is it because it's expensive, or what's going on there? Is that something people should do? What's the story there?
I think it's basically a tool to satisfy your curiosity itch. If you think you might have had it, but aren't quite certain, it'll tell you whether you've had it before. It doesn't tell you if you've had it now. You could have it now, but what it does tell you is that you've had it at some point in the past. But what I will tell you, in fact, this was just a conversation I had this afternoon, antibodies drop off pretty quickly. And the studies that they're showing is that typically the levels of protection, you have an level of antibodies within your system that provides a level of protection. The drop-off point below which it probably doesn't provide protection is within 4 months. There's a steady decline down. So even if you've had it in the past, if you had it longer than 4 months ago, it's no guarantee that you're protected from getting it again.
I guess it's too soon to know if you're asymptomatic the first go around that you would be on future go rounds. That's like around 3 or 4 bends in the road before we know that, right?
Well, the thing about being asymptomatic, the truth of the matter is everything is a symptom. I don't know if you've gone through the CDC list of symptoms, but it's everything from body aches to sniffles to headaches to fever. The only thing that's not on there is blunt force trauma, but who knows? That could be a causal event. But in fact, it's funny because in this past week, as people are getting the flu vaccine here, we're going through the flu vaccine process at TMH. And there's been a reminder for everyone out there that once you get the flu vaccine, it often can create a symptom effect for a short period of time, and to be careful not to confuse the symptoms post flu vaccine with COVID symptoms. In other words, if you got a flu vaccine, you don't necessarily need to rush out and get a COVID test right off the bat.
That makes sense.
Yeah.
You talked a lot in the past about the jails and prisons being responsible for a lot of our cases. Is that still the case, or is it kind of moved through there?
The state's been actually pretty good about that. I'll tell you, the state has really stepped up in a couple of areas and been a model for the rest of the country. Prisons, they've actually done better than most. You can't disseminate prisoners. I mean, unless you're going to let them all go, they're going to stay within an area. And they've done probably a better job than most in managing that. Now, the numbers in the prisons have gotten much, much better, mainly because I think they may have reached herd immunity. I mean, they really have been in an environment where if you're going to get herd immunity, that's where it's going to be. But they managed through that process relatively well and kept the number of severe events down. The other area where the states did just a phenomenal job was in the area of long-term care. They set up isolated nursing homes to basically aggregate COVID positive nursing home patients. So if you were nursing home A and you had a positive nursing home patient, rather than put them in a wing or kind of offset them or try to manage them within your environment and allow for the potential spread to other residents, what the state did was set up COVID nursing homes where they would be transferred there and managed until they tested negative and then moved back. That was just it seems pretty basic, but believe it or not, a pretty novel approach compared to other states. Now they've actually trained each nursing home how to manage those patients better while they went through this process. And we're not seeing the kinds of activity, high levels of events, and certainly not the deaths in nursing homes that other states have seen. So I tip my hat to the state for really doing a great job.
You've used the term herd immunity a couple of times, and that's become a little bit of a political term, been used with derision by some and as almost a touchstone for others. What does that term mean to you? And is it realistic for us to get there either pre or post vaccine?
As a population, almost impossible to get there before the vaccine. I mean, there are some debates on what is herd immunity. Is it 30%, 40%? Most people tell you it's really 60 to 70%. Doesn't really matter. The more people who have it, probably the closer you get to it. But then again, if antibody levels drop that quickly, then you basically have a second cycle back. The one country that tried herd immunity early on was Sweden. That was a failed experiment, and they'll tell you that. If you look at their mortality rate to cases, it was in the 6%, above 6%. United States, even though we've had more cases, our death to positive cases is 2.8%. So significantly lower than Sweden. Sweden actually did try to get there, but I think everybody has retreated from that. If we go another 2 or 3 years without a vaccine, then we probably will hit herd immunity. But I'm hoping that we get to a vaccine prior to that. And all indications are that we will have a vaccines available within a reasonable period of time.
So let's talk about vaccines. And my question is going to be, tell me everything you know about them. What, when, how, what, just unload your brain on the latest on vaccines.
Well, a lot of activities going on there. First of all, let me just say there's a lot of money in vaccines. The first CARES Act, the federal government provided $10 billion with basically a blank check provision. Beyond that, whatever basically they're saying, we're going to give you $10 billion now to create a vaccine solution. And if it costs more than that, so be it. If you look at the HEROES Act that the House has put out there, and there's a debate about what will get passed, what won't get passed, but this is probably one of those that will be carried over by the Senate if it does. There's another $25 billion in that bill, that act, for vaccines. So we're talking about phenomenal dollars being thrown at this. That being said, there is a fair amount of activity. Right now, there are 4 vaccines in phase 3 trials. You've got Moderna, Pfizer. Those are both RNA vaccines. They have some limitations. I'll mention those. You got AstraZeneca and Johnson & Johnson that are out there. They're testing and having some pretty fair success. There are some limitations, I won't say limitations, but some challenges with the first 2. They're RNA-based vaccines. They require super cool temperatures. They have to be stored, and they have to be stored and transferred in, I believe, 65 degree below zero environments. And most doctors' offices and CVSs don't have that capability. But that's a challenge. The other 2 don't. But again, they're making progress. But what we do know is that there is some planning. The federal government has already, through the CDC, identified a vaccine distribution contract. They've contracted with McKesson to be the distributor of vaccines. So there's a plan in place there. That's already in place. They've identified 64 distribution jurisdictions, of which Florida is one of 5 pilot jurisdictions. The 5 pilot jurisdictions are us, California, North Dakota, Minnesota, and the city of Philadelphia. Don't know why the city of Philadelphia, but well, what they're trying to do is identify different types of environments, different sections, et cetera, and they're going to learn from those challenges. The state of Florida, because of that, has already, and I don't know what the number is today, I read a week or so ago, they've already purchased 5 million syringes and basically kits for distribution of a vaccine, and they've already stored those. So there's already steps in place to get ready for the distribution. Now, if I'm guessing, based upon what I'm reading, we, on the off chance, might have something that would first become available by the end of the year, but my better bet is going to be the first quarter, sometime in the first quarter of next year, would be the beginning of a rollout. And that rollout will typically go to your most at-risk individuals, elderly, et cetera, first responders, people on the front lines of healthcare. And then the remaining population would be addressed in probably the second and third quarter. But that is straight up a guess. But it's just based upon what I'm hearing.
Hey, by the way, viewers, thank you for sending in so many terrific questions. And if you have a vaccine question, now is the time. And I don't know if you'll have the answer to this, Mark, but the question is, how effective should a vaccine be before approved for distribution? And they have a little percentage sign next to how effective. Do you have any idea on that?
It should work. How about that?
Yeah.
I think the number they're targeting minimum of 30,000 per group for a phase 3 trial, and this is different because you really don't have a control population in a normal environment. You can't expose people to COVID purposely. You have to vaccinate people and put them out in the community and just kind of see how they compare to the rest of the parties, and that's why this might take a little longer. But really, if we get a vaccine by next year, that's really breakneck speed for vaccines. I mean, it's just unheard of to have something that quickly. Usually it takes years to get something. But I couldn't tell you the numbers, but I will tell you they have halted some of the vaccine testing for short periods of time when they've had even a single event that would cause some concern. But they seem to be working through it. Right now, my confidence level is high that we will have effective vaccines within a reasonable period of time.
And would you expect this would be a seasonal vaccine like the flu, where you would get it once a year at the start of some season, or what's the duration of these things typically?
That's what I couldn't tell you. It would seem, just as the flu shot is not one flu. It's basically a cocktail it covers a cocktail of flus. I mean, they guess every year which ones are going to be the principal ones, and they throw it into a mix. This would be a type of a flu. It's a very severe type of a flu. It's basically a virus. Logic would say that they would mix it in the future, but I don't know.
Okay.
I mean, that's off my grid to answer, but yeah, you could logically think that it would be wrapped into it.
Okay. So let's go back to your staff for a second. You talked about the steps you've taken to protect their physical well-being, and I think that's an amazing statistic on the ER, that there haven't been any that have been passed there. Well, what about the mental and emotional toll? What have y'all done on that area to make sure your folks, I mean, I'm sure they are under a lot of stress. How have you taken care of them in that regard?
That one, that's always a challenge. We try our best, but it's a stressful environment, and we get, like any organization, criticism, and sometimes rightfully so. I won't say that we're perfect, but one of the things that we try to do is communicate. We've been very focused. First of all, one of the things we try to do is create the safest environment possible for them. I mean, if we can take that worry off of them, that's at least some part of the emotional toll that we can help bear. We can help to moderate. So that's the first thing. We do have EAP programs. We have spiritual care folks who work full-time here, who make themselves available. Probably the biggest things, though, we've really focused on education. And it's not just, quite frankly, the issue of COVID, but we've layered on the issues of social injustice, concerns in the country, the globe. We're trying to do a lot to keep our crew, and we have a pretty big family here at TMH. We have over 5,000 family members. So we try to educate. We try to listen to them. We do surveys on a routine basis. One of the things that has been a learning lesson. And every event gives its opportunities. You look for the silver linings and the opportunities from every environment. One of the things that we're getting out of this is developing mechanisms to communicate and address issues faster. And let me explain that. When we started with COVID, when it became an issue, we developed COVID huddles. Every single day, we would bring our teams together and we would do a quick huddle in the morning, make sure everybody was updated on what was going on, found out where the challenges were, identified issues on PPE, looked at all the other supply chain issues, looked at volumes, how to shift. We looked at staffing concerns. I mean, we did all of this. And it was a really good lesson because it helped us manage. I think it gave us a very effective tool to manage day to day the activities in a very quick response mechanism to the challenges that were right at hand. But what was most interesting was, to me, was during this experiment, it was an experiment, was not just what happened during the COVID periods, but the post-COVID meetings, the post-huddle activities, the other conversations that occurred. And what we realized is that we could create a chain of communications up and down the organization, not just related to COVID, but to everything. So one of the things we learned from that, we went out and did some studies on how we could create leadership huddles, daily leadership huddles. So starting, actually, it was early September, we started leadership huddles that go in two phases, one at the department level that then go up to a leadership level. And every day we have these at set times. And what we're doing better is communicating up and down the chain and addressing issues real time, which before we'd have to rely upon emails and forms to be filled out, et cetera. So that's one of the things we've done, is to create a better chain of communication up and down. And then also, quite frankly, Stephanie Durspolsky and Daniel Buchanan have created a very strong communication internally called Spark. It's an intranet program. Everybody is aware of it. We put that into place. And then we've also, through our medical staff, we started there and now trickling over to the rest of the house, developed what's called a Volt system. It's an internal texting system that allows us to text in a secure platform so we can share information. And that's given us another tool. So what we've really learned to do is to create better communication chains and quicker communication chains to improve.
Yeah. So we're getting a lot of questions. I want to go back to college kids. Okay. Daggone it. I got one of them. I've had two others.
Oh yeah, I'm right there.
What?
I'm right there too.
Yeah. And so there's a lot of concern about this move to phase 3, and there was a lot of pictures this weekend of bars and clubs over near campuses that were filled with unmasked college kids. What do you anticipate there? And I mean, so, there was some of that, maybe a lot of that happening at the start of the month, start of September, I guess I should say. Is it your expectation? And I had a meeting today where an intern at a business I was meeting at said, I don't know anybody that hasn't already had it, right? And this particular intern had gotten it at home. I'm not sure where home was, but out of town. So you put all that in a stew. Is your feeling, this probably isn't going to cause a big spike, or, oh boy, the big spike's coming and this is it? Where do you fall on that spectrum?
Well, first of all, their positivity rates at an FSU campus are falling. It's still high, but falling. So that's a positive. Some of the questions that people have asked is, are we more at risk because we're in a college town than if we weren't in a college town? I would say the logical answer to that is yes, because we're going to have more kids who probably are contracted. College kids do what college kids do. But at the same time, maybe Tallahassee's taken one for the team, so to speak, because we all know that college age kids are going to aggregate regardless of where they are. If they're in college, in a college community, they're going to gather. But if they're home, they're going to gather. So in the reality, they're probably better to be all together in a relatively insulated environment. And that campus is pretty insulated at the end of the day. Spreading it among themselves rather than out in the Sarasotas, or even for that matter, up in the Killarn estates, coming together with friends, contracting COVID, going back home, sleeping in their household bed and seeing their parents, grandparents, aunts, and uncles. They're probably better staying in a campus environment where they're only seeing each other. So I would say at this point, if we haven't seen a significant transition to the community, we're probably not going to have a spike. I'm not saying there's not going to be any transmission, but so far, if we were to see it, if we were to have a spike, we'd have seen it already.
When the virus first came on the scene, there was a lot of talk about a second wave. I'm talking about back in April, and that was really before we had this kind of draining down from the northern states into the southern states, and it was the big Sun Belt wave in the summer. What is the thinking now on a second wave? Is it still assumed that that's going to happen? Did maybe the summer kind of cancel it out, or we just don't know, and we'll have to wait and see?
Don't know. And the reason why I say that is because I think it's pretty unpredictable. If you look at New York today is hitting record highs, record highs for this wave. They are in a second wave. You go into some Midwestern states, they're hitting some record highs. You look at Europe. Europe is now hitting some huge numbers. I think today they had a record number total of new cases, over 100,000 in Europe. Spain is back off the charts. So there is no guarantee, no matter what you do, that somehow, some way, once you achieve a certain level of performance, it's going to stay there. I wish I could give you an answer. Wish I had a crystal ball, but my belief is that until we have an effective vaccine that gets out to the community in a broad sort of way, it's a little bit of a crapshoot.
Mm-hmm. Let's talk about treatment of COVID patients and how that has changed. So in the early days, I know there was a lot of talk about the ventilators, and there's been a lot of different drugs that have kind of been in and out of the picture. How have things changed in that regard since you and I first spoke, or since the virus first came on the scene?
Well, I will tell you, this is a category that I remind people I am not a doctor.
Are you phoning a friend?
I'm going to use a lifeline.
That's all right.
Can I do that?
Yeah, absolutely.
All right, we're going to call Dr. Dean Watson. He's our Chief Integration Officer, also Chief Integration Officer for CHP, and he better answer the phone.
If I was him, I wouldn't pick up.
I just introduced you. I told him that you were the Chief Integration Officer at TMH as well as CHP. Dean is actually, I will tell you, he is one of the best doctors I've ever known, and I've known a lot of doctors. And I'm not just saying that because he's on the phone. I will also just personally tell you, he saved my life. I credit him for pushing me to get basically he literally forced me to get on a treadmill after really pestering me to determine that I had an occlusion in my heart that could have been fatal.
Yikes.
But yeah, that was a number of years ago. But anyway, that's a different story. But anyway, yes, this is Dean Watson, Dr. Watson on the phone. Doc, can you re-ask the question for Dean?
First of all, Dean, can say something so we know we can hear you.
Yes, I can hear you.
Okay, and he needs to speak up as much as he can.
He needs to speak up a little louder. I got all your way up, Dean, but.
Yeah, the question is just, how has treatment changed as this thing has evolved? How does treatment look differently today than in April, for example?
Yeah. Can you hear me, Mark?
I can hear you fine.
Okay. Yeah. So that's a great question. And as Mark and I and the rest of the team talk on a daily basis, treatment changes on a daily basis. And back in March, April, really everyone was struggling to figure out if we had anything that would work. We were struggling to figure out how to maintain people's lives with basic care, basic ventilation care, basic intervention care. Now, literally every single day, we are changing management. I just would remind everybody, that's watching or listening or whatever, that in healthcare, studies basically take months to years to run on any type of treatment. We're advancing things as rapidly as we can, but just as an example, things that people thought had worked before we realized don't work as well, we stopped using them. I mean, everyone knows, discusses plaquenil and other things, but right now we're using assessment tools to look at how to keep people's blood thin so they don't clot, or give them medicines to help them clot. That's how crazy this disease is. We're using vitamins and minerals, vitamin D, which is, actually being shown to, if you're vitamin D deficient, you are more likely to get sicker than if you're not. So vitamin D, vitamin C, zinc, simple things, melatonin. But I just remind you that, again, these studies are not completed. They're just early findings. And the other things that we've seen, excuse me, I just got done exercising. So, is that using some medications that we use for cholesterol lowering, their anti-inflammatory effects appear to be beneficial. Using steroids in people that are really severely ill or critically ill. We started off in March, April, scared to death to use steroids for many reasons we can talk about. But now what we've found in folks that are severely ill or critically ill, those that are having problems breathing or showing these mass inflammatory processes or massive inflammatory processes, dexamethasone and other steroids actually works. Using antivirals, remdesivir really was not used until, recently. It was used for other things, other types of viral illnesses, and they said, well, let's give it a shot. And as a reminder to everybody, when you would think, well, why can't we just come up with a simple viral antiviral medicine? Remember, these viruses change rapidly, and you're trying to target a specific portion of that virus without destroying the cell that it's in. The collateral damage, that's hard to do. And so that's why you see people struggling with these antivirals. And remdesivir appears to have some benefit in reducing mortality. There's other, monoclonal antibodies that are coming out. You guys saw the antibody cocktail that Regeneron generated. Lilly's coming up with one. There's all kinds of these monoclonal antibodies that they're pushing out there that affect and attack the virus itself. And then, of course, convalescent plasma. People donating their plasma so that we can use their antibodies that they generated to attack this virus. So you start from March and come to today. I just listed a bunch, I don't know what, 9, 10 things that we're using that we were not using then. It's just rapidly changing. And it's just fascinating to watch science. So everything we're doing right now is going to benefit us in the future. This rapid technology, these rapid treatments, these advances in testing technology, I'm sure Mark talked about the TMH FSU lab, all of these technologies are fascinating to watch. The unfortunate part is for everybody, we don't have a cure. And until we get vaccines, and there's another thing that's moving rapidly, vaccines. And, over the next 3 to 4 months, you're going to see significant movements on vaccines. We're seeing a lot of good outcomes from a lot of these vaccines that are being tested right now. So hopefully by the new year or there a little after that, we'll have some vaccines. So a lot of good things happening. I hope that was probably a long-winded way to answer your question, but I appreciate the opportunity.
No, so let me just follow up with a couple things there, Dean. First of all, you mentioned some things that I can go buy right now: vitamin D, vitamin C, zinc, Are there any preventative benefits to those? I guess they can't hurt you, right? So is there any reason for people not to take those things, and could there be a benefit to them taking them?
Yeah, the argument, believe it or not, so even before COVID, and I'm at the age where I'm supposed to be taking my vitamin D anyway, but so the argument is that, quite honestly, these are really beneficial. Vitamin D is really beneficial in individuals that are deficient, that have been diagnosed as deficient. There is evidence showing that outcomes are worse if you're vitamin deficient. The argument from the clinical side is, look, as long as you're not overdosing on these things, you're not taking drastic doses. Vitamin C, which is water soluble, you're going to pass it if you take too much anyway. That's not going to hurt you. It is beneficial in many ways with regards to your immune system. Zinc is beneficial, although I'm not taking zinc, but I will tell you that there are people that believe in zinc when it comes to the antiviral properties and immune system elevation properties. Vitamin D clearly has a lot of evidence out there pre-COVID that it's beneficial in reducing viral illnesses. So you may want to, what do I take personally? On a daily basis, I take vitamin C and vitamin D on a daily basis. But again, I was taking vitamin D anyway because I'm of the age of vitamin D deficiency. And then again, melatonin. This is a recent one that has been come out, and I'm going to keep reminding everybody, all these studies are ongoing, so everything is a work in progress. But there's some smaller studies on melatonin that show that its anti-inflammatory properties are beneficial in fighting viral illnesses. So I would tell you, look, taking vitamin C is beneficial, taking vitamin D is beneficial, low-dose zinc is beneficial, and melatonin, if you're using it as a sleep aid at night, looks to be beneficial in reducing the severity of this disease. So I'm a big advocate of vitamin C and vitamin D, and the others are up to you all.
So there's going to be a 8 o'clock run on CVS and Walgreens right now.
I've already bought stock in all the vitamin C, vitamin D manufacturers. I'm going to make a killing on that in the morning. No. So the last thing, and this came from a viewer, Dean, and that is, does TMH have ready access to all of these fancier drugs that you mentioned, remdesivir and dexamethasone? I'm sure I said that wrong. The monoclonal antibodies. I mean, are those in wide distribution, or do you have to be on a waiting list? Or how does that work?
Yeah. So the good news and some good news. Remdesivir, which again was used for numerous other viral illnesses in the past, was very difficult to get, and we talked about, well, what happened to March, April to today? Remdesivir, now we have plenty. We were one of the hospitals that was identified for many reasons to receive large quantities of remdesivir, and now they've produced it to a point where most hospitals can get it. Dexamethasone we have. And just as a reminder, for antibody cocktails like Regeneron or Lilly's, those are all investigational. We can get those if we were willing to, join in on research in that area. We have not done that. Some of the other monoclonal antibodies, the anti-inflammatories, this is way too much, but some that focus on interleukin-6 and others, we have those. We reserve those for our critical care docs to determine when we want to use those. So the short answer to that long answer is yes, we have them all, and yes, we have access to some of the investigational drugs if we're interested in participating. We haven't needed them, the investigational ones. We've done well with the ones that we have, and they were comfortable, have been studied enough to be beneficial.
Dean, one of the things I mentioned earlier was the expertise that our doctors have developed, that we've identified doctors to specialize in COVID management. Do you want to mention anything about that?
Yeah, so early on, no one likes to go through this kind of stuff, but early on we felt strongly as a team that we should pick a small group of providers to focus on this that would allow us to, one, minimize exposure, and to two, to become experts so we don't make mistakes, and or try not to make mistakes. Nobody's perfect, but We selected a small group of hospitalists, and I'm involved, but I'm just the old stinker that helps guide a little bit here and there. And then we picked a few pulmonologists, and we actually worked with radiology and others to make sure that we had a select group knowing. And I just, again, remind everybody early on in this, and people forget this because memories are short, but when we started in this journey, we could not get tests. So when we created this group, we were housing people for weeks, 10 days before we got a result back. So we had folks in isolation with our doctors trying to figure out what to do without knowing what management structure we had to put in place. But these are heroic people. I mean, they're in there saying, we're going to go for it. We're going to lock them down into a specific unit, and we're going to do this right. But we're going to have to sit here and wait for our test results to come back. Now let's move forward 6 months or whatever. And now that team is still together. I will tell you that this team, none of which have tested positive for COVID because they're so focused on doing the right thing. And now we can test. We get our results back in 90 minutes to 3 hours, depending on which system we're using. So it's a godsend. The difference in what we have today with regards to testing, our capabilities. The team is amazing. Again, early on, they were just a few of us taking 24/7 call for the first 30 days to determine who got tested and who didn't. I mean, it was one of those things that you just hope you only have to live through once. But now they've built to just an amazing team, and I'm really proud of it.
Let me tell you, the one thing that does differentiate Tallahassee from just about any other community out there is the testing. The research testing relationship we have with FSU, Dr. Dennis, Dr. Ostrander, has allowed this community to create a testing vehicle that, I won't say unlimited, but we've never hit a number that we can't reach as far as PCR testing in any single day. We have tremendous capacity, and that's been a sea change for how we manage patients in our community.
Yeah, that's huge. Yep.
Okay, Dean, thank you so much for the lifeline. I feel like Regis here, but the last thing I want to ask, Mark, because we're running over a little bit, is there's been a lot of talk about the determination in deciding whether to list COVID as a cause of death for a patient. How does that work? Because we know we got a lot of people with, one of the things that leads to fatalities is these comorbidities, these folks that already have some physical problems. How is it determined if something is listed as a COVID death or not?
That's a good question, and it's not as simple as being black or white. There's a lot of gray in it. But the reality is, it really is a question of causation. No one dies of COVID per se. They die of some other effect, some other shutdown of a body system. It could be, a vascular event, a heart issue. It could be a respiratory event. It could be a whole bunch of other things. But the question that you would ask is COVID a causal contributor to that death? So take, for example, a patient who has COPD and they get COVID and they die of a respiratory issue. Yes, or pneumonia. You have pneumonia, and yes, COVID's a part of that. Yes, that COVID is a causal agent for that. So in that situation, yes, COVID is going to be tagged as a reason for death. If you have a motorcycle accident and a head trauma, even if you have COVID, the COVID isn't a causal reason for death. It's the head trauma caused by the motorcycle accident. So it's really kind of a balance. You have to look at, was it in fact a contributing factor to your death? Is it one of the things that pushed you over the edge, or is it not? So it's not necessarily if you have COVID, will you be counted as a COVID death, but whether or not COVID is a causation event for that fatality.
I understand. Well, look, to our viewers, your questions were excellent. You unsurprisingly showed me up by having much better questions than I spent too much time formulating, so I thank you for your participation. Mark is one of the great leaders in this community. I don't say that to suck up. He's been a chamber board chair. He's been active with the United Way, and he has run a just terrific hospital here that contributes not just to the health, but in many other ways to this community. So, and you know, it's not easy stepping out here. This is controversial stuff. We're a month away from a volatile election, and for Mark to step out and continue to answer these questions and inform our community, I think is a tribute to his leadership. So I really appreciate you doing it, Mark, and maybe we'll get a chance to do it again, although hopefully this thing will be gone soon and we won't have as many things to talk about. If you want to rewatch or share the conversation, it will be available on Facebook immediately, and it will be available later in podcast form on the Village Square Cast, which is available to stream wherever you get your podcast. So thanks again to the Tallahassee Democrat, which live streamed this and co-sponsored it with us, to Tallahassee Memorial Healthcare, which also simulcast this, and of course provided Mark, and of course to the Village Square, which is a real treasure in our community. Liz Joyner, Eliza, and the whole team there does a fabulous job providing us this forum to talk about things. So we'll keep these conversations going. Mark, thank you so much.
Yeah, one last comment. You said a lot of nice things about me. Just realized that, quite frankly, I get credit for everybody else's work around here. We have a great team. Happy to receive some of the credit because it really floats back to the rest of the organization. But overall, it's an organizational thing. And our TMH family, my family at home, they do a lot to allow all of this work to get done.
Great. Well, thank you again, everyone, for participating, and I hope everyone stays safe. Please stay safe, and have a great night, and we will talk to you again soon.
Thanks, Skip.
Good night, everybody.